So, welcome everybody to our new podcast about endocrinology. So, today the next topic for today's discussion is a posterior pituitary. So, we have two delegate doctors, Dr. Khadka and Dr. Anmol Paudel. So, I'd like to start. So, posterior pituitary, we would discuss about ADS, oxytocin, and diabetes insipidus.
Okay.
So, Dr. Khadka, I want to know a few things about this AVP.
ABP is actually 8 amino acids.
Yeah, it's arginine vasopressin.
Arginine acid.
Is that
how many?
amino acids?
Yes.
I am not sure, doctor. So, Dr. Paudel, do you know how much amino acids in the AVP?
Vasopressin.
The arginine vasopressin.
I actually don't know our number of
It has two receptors, B1 and B2.
B2, yeah.
The main mechanism action would be collecting B2
Yeah,
is
in
collecting
collecting duct.
collecting duct,
Yeah.
collecting duct, and B1 would be almost in every blood vessels.
Okay. So,
Some central nervous system nuclei.
smooth muscles you want to say?
Smooth muscle.
Basically.
So yeah. So there used to be a resuscitation kit. In a resuscitation, there used to be a vasopressin in old days. Like
Oh.
a child in
Yeah,
vasopressin,
yeah,
we
yeah.
used to study.
Yeah.
So maybe that is related to
Blood vessels.
adrenaline like action.
Yeah.
Mechanism action was there.
Oh, yeah.
Maybe.
Oh,
And there is some central nervous system nuclei
yeah.
where the B1 receptor is present.
Okay.
Coming to
So,
the
yeah. So, is ABP and ADS is different or same?
arginine vasopressin and
Antidiuretic hormone.
that must be the same.
They both are same, huh?
Both are same.
Yeah. So,
The function is antidiuresis.
yeah. Actually, these ABP and ADS are in this. Do you know the herring bodies? This is very unique term, so I just want to say.
Herring bodies.
Yes, ERRING, herring bodies at the axon terminals of the posterior pituitary. Actually,
Cushing syndrome.
Cushing, I'm not sure, but thing is that this ADH and oxytocin, they are basically stored in this is the herring bodies in the axonal terminal of the posterior pituitary.
Okay. It's just like vesicles where the storage is happened. There in about to release, there is in the tip of the posterior pituitary neurons.
Yeah.
Okay.
So you just told that like ABP binds to the B2 receptor.
Yes.
Yeah, this is actually serosal surface of the renal tubules.
Serosal surface.
Yeah.
Okay. Location.
Yeah. So there is
serosal means you mean towards urine or towards plasma.
serosal.
What do you mean by serosal surface?
I think it's tubular, intratubular things.
Yes.
What I understood is
this is a tubule. Inside it is a urine.
Yeah.
Outside this is a plasma or blood or whatever.
Yeah.
Serosal surface, you mean this surface?
Inner aspects.
Inner aspects. Okay.
Yeah. So there is one syndrome. This is a very interesting name. This is the Wolfram syndrome.
Wolfram syndrome. It is associated with diabetes.
Yes.
Diabetes insipidus.
Yes, sir.
And what is the third component?
Insipidus and mellitus both.
Both.
And one is the optic atrophy.
Optic atrophy.
Another is the sensorineural deafness. So you can just remember like mnemonics diamond, DI for the diabetes, DM for the diabetes mellitus, OA for the optic atrophy, D for the deafness means sensorineural deafness. So DIMOAD, diamode. I mean diamode, not diamond, it's diamode.
Okay.
This is basically the interesting term. So just I just explain about this syndrome. So we have nephrogenic diabetes insipidus.
Nephrogenic versus central.
Yeah. Basically nephrogenic diabetes insipidus causes by the few drugs. Do you know some of them?
Aminoglycosides.
Yes, sir.
And
we have
chemotherapeutic agents.
Some mood stabilizer, great mood stabilizer.
Lithium.
Yes, sir. So one the cytotoxic drug. Do you know that's cisplatin?
Cisplatin.
And one anti-tubercle drug.
Pyrogenamate.
I think rifampicin, sir.
Rifampicin.
Yeah. And there is some genetic cause for the nephrotic diabetes insipidus also. So this is basically the mutation in the aquaporin channels.
Aquaporin channels. Okay.
Yeah. This can lead to genetic cause can lead to the
peripheral.
Nephrogenic peripheral one diabetes insipidus, and it's basically it's X-linked recessive, and sometime it is AS and AD. So means genetically is all three type of the inheritance. One is autosomal dominant, one is recessive, one is X-linked recessive. So how would you differentiate like central diabetes insipidus, psychogenic polydipsia, SIADS, sir? Do you have some important clue like you say on the basis of this fact we can differentiate most of the entities?
Central diabetes insipidus, psychogenic diabetes insipidus,
and SIADS.
SIADS system.
Central and nephrogenic both one.
In central means pathology in the posterior pituitary. I recognize that.
Yeah.
The ADS is not appropriate, not released from there.
Yeah.
Even if there is ADS, but the receptors are not adequate. That means peripheral distal.
Nephrogenic,
both way.
Yeah.
Our psychogenic
and SIADS. Basically, what I recommend, like you have to look for the plasma osmolality and urine osmolality. These two are the very important thing to differentiate them each other. Like if you say plasma osmolality is high and urine osmolality is low, means you can say this is the condition of the nephrogenic or central. So when plasma is high and urine osmolality is low, means this is the central or nephrogenic diabetes insipidus, and there is a relative hypernatremia in central or nephrogenics also, relative hypernatremia, and you can treat with the few drugs to treat the central or nephrogenic diabetes insipidus. We have some diuretics to treat the central or nephrogenic diabetes insipidus. The thiazide one we can use for the this is for actually nephrogenic, and for central
demsicycline.
Yeah, desmopressin. Desmopressin, this is for the central one. So this is for the central or nephrogenic diabetes insipidus. And psychogenic polydipsia, there is decrease in the plasma and urine, both osmolality is decrease. But
psychogen is
both is decrease. Thing is that here is
water intake is increased, in this kind of
excessively water intake. So sodium concentration is there is hyponatremia. In nephrogenic there was relative hypernatremia, but in this case it is hyponatremia.
Yes, in psychogenic every 3 parameters
is low. So SIDS thing is that urine osmolality is high, other two like plasma is low and sodium concentration is low, hyponatremia.
Yes.
So how do you treat this SIDS?
System of inappropriate
antidiuretic hormones. So beptans you can give.
Okay.
Yeah. Okay. So drug of choice is this is a very new one. This tolvaptan is a drug of choice. So basically if you say low osmolality, how much osmolarity is low? Means
the normal osmolarity is 275 milliosmol to
300 milliosmol. Okay.
So less than 275 would be hypoosmolar.
Less than 300 sorry,
less than 275 would be hypo.
Yes, you can consider if less than 300 is a high, less than 300 is the hypoosmolarity. You can in urine osmolarity. I'm talking about urine.
Urine?
Yeah. And 24-hour volume of the urine, if say more than 40 ml per kg per day, that is also considered as a hypoosmolarity, low osmolarity. And for hyponatremia, how much excretion of the sodium you need? You say like this is the hyponatremia
per 100.
Yeah,
20.
yes, exactly. This is more than 20 milli equivalent per liter is for the hyponatremia.
Per little sodium
Excretion in urine, sodium excretion. So, Dr. Powder, so I want to ask a very simple question. So, specific gravity changes in the case of this diabetes insipidus?
It remains constant.
it has to be water content increase भयो नि हैन
If water content is increased means it would increase, I think.
but specific gravity is increased.
Yeah, I'm not 100% sure. I want to check. So we'll check. Okay, sir. So, but thing is that one is important fact is that low fixed specific gravity in the urine is a this is on the chronic glomerulonephritis. This is fact.
This is fact. That resembles in the CKD also, early phase of CKD. Yeah, present as polyuria, blah blah blah. There also the specific gravity of urine will be decreased in the early phase. Stage 1 and 2 phase of CKD even. Means it resembles like
low and fixed is on the chronic glomerulonephritis is
it is
more same like first and second stage of the renal failure.
yes, chronic
Renal failure. So by this we just finished the discussion on this posterior pituitary hormones. So